Okay, now we're going to be finishing up our last Roman numerals. We're going to be going over the abdomen, the musculoskeletal system, and last but not least, the neurological system. Found it. Anyways, we will finish up with those three, and that will be the last of it. Thank you very much, and hope you've enjoyed this course. Enjoyed having you here. If you have any questions or concerns, as always, please let me know. Alrighty then, let's get back to our abdomen. And the abdomen is going to be, as you can see, worth 12 points. This starts on chapter 21 on page 536. So the first thing it says you're going to do is inspect the skin. So you're going to inspect the skin, the umbilicus. You're going to be looking at it. You're going to be looking at the contour. Is it flat, rounded? Is it scaphoid? Is it protuberant? That would be more like me. This is on page 536 that it talks about the contour. So it's one of those, and you will decide which one your patient is. You're also going to be looking for pulsation, scarring, tattoos, and documenting anything that you see. Also looking for striae, stretch marks. Then you're going to be auscultating the four quadrants, okay? As you're auscultating, this is on page 539. It says you're going to depart from the usual examination sequence and auscultate the abdomen next. So you always inspect and then auscultate. This is done because percussion and palpation can increase peristalsis and give you a false interpretation of bowel sounds. So this one you do different. Inspect, auscultate. When you're doing bowel sounds, they can be normal, hyperactive, or hypoactive. So you're going to be auscultating. You have to listen for a full 5 minutes before you can actually say that they do not have any bowel sounds. Borborygmus is when they have real loud peristaltic sounds, when the stomach's growling, high-pitched sounds. So you're going to say they're normal, hypoactive, or hyperactive. Hyperactive bowel sounds are very loud, high-pitched, rushing sounds, indicating increased mobility. Hypoactive or absent, you may hear after abdominal surgery if they've got some kind of inflammation of the perineum. So those would both be considered abnormal. Then after you get through auscultating the four quadrants, then you're going to actually also auscultate vascular sounds. Now you can do that here, or you can do that in the section above where it said auscultate for bruise abdominal. And it shows you on page 540 where you're going to auscultate. You're going to auscultate at the aortic, and then each one of the renal arteries on both sides. Then you're going to go down right below the umbilicus and get the iliac arteries. And then you're going to go down into right above the femoral artery and listen on both sides. So it's the aortic, the renal, the iliac, and femoral arteries that you're going to auscultate. And what you're auscultating for is to see if you hear any kind of bruise, and that would be that swishing sound. It's a blowing sound. They may have stenosis if you hear that, or some kind of occlusion of the artery. So you always want to listen to make sure there's no kind of stenosis there. Also, you're going to inspect again the carotid artery here. Oh, I'm sorry, on the wrong side. Oops, sorry. Then you're going to percuss. Okay, and remember we talked about percussion earlier. With here, we're going to percuss different things. First, we're going to do a general percussion over the stomach, and we're going to be listening for tympani. And it shows you how to percuss on the bottom of page 540. Dullness is heard over distended bladder, a lot of fat or adipose tissue, or a mass. But you should be able to hear tympani otherwise. When you're getting ready to inspect the liver, for the liver span, then it shows you how to do that on page 541. You're going to percuss or map out the boundaries of certain organs, starting with the liver. So you would begin in the area of lung residence, like she's doing on page 541, and you would percuss down the interspaces until the sound changes to dull. So you would percuss down until it goes from resonance to dull, and you mark that spot. Usually a little bit, about 2 inches or so from the nipple lines where you'll hear that. You will mark the spot usually about the 5th intercostal space. Then you will find abdominal tympani. So you'll start down below and start percussing upward to the midclavicular line and mark where that sound changes from tympani to dull, and you will mark it. Then you will go back and measure the distance between the two marks, like she's doing on page 541, and the normal liver span in adult ranges from 6 to 12 centimeters. The height of the liver span correlates with the height of the person, so taller people is going to have longer livers. Males may have slightly larger than females, but overall, the liver mean is about 10.5 centimeters. Okay. Now, an enlarged liver indicates hepatomegaly, okay, that they have an enlarged liver. So if you're getting greater than 12 centimeters and they're not real tall, then that indicates they've got some liver enlargement. Also, you're going to palpate the spleen. It shows you again. You would do that the same way. You would percuss the area down to dull, to where it goes from again resonance to dull, and that's usually at about the 9th intercostal space on the liver. And you would also listen from tympani up. And you could actually have them take a deep breath when they do that. And then it should not be a very small. The area of splenic dullness normally is not much wider than 7 centimeters in the adult. So it's a little 7 centimeters or less. So it's not as big. Then on the percussing all 4 quadrants again, and you're listening for tympani. Then palpation, you're going to start with light palpation. And when you do light palpation, you're going to lightly palpate all the areas. Once you get through lightly palpating all the areas, this is on page 545. It shows you how to do the light palpation with the first 4 fingers close together, depressing about 1 centimeter. Okay. You're looking for them to do muscle guarding or becoming rigid or complaining that it hurts. Then you'll go to deep palpation, and you always do that last where they're hurting. And if you suspect appendicitis, do not do that. Let the physician do that. You will use the same technique, except this time you'll go down about 5 to 8 centimeters or 2 to 3 inches. You'll move clockwise, exploring the entire abdomen. You're going to palpate the 4 quadrants. You're going to palpate the liver. You're going to palpate the spleen and palpate the kidneys. So when you're getting ready to palpate the spleen and the kidneys, it shows you on page 548 how to palpate the liver. You take one hand behind the liver. You take your other hand and go up under the 11th and 12th ribs and lift up to support the abdominal contents. Place your right hand in there. Push down deeply. Ask the person to take a breath slowly. With every exhalation, move your palpating hand up just a little. You may feel the edge of the liver bump your hand, but it is never normal to feel a full liver. Your liver should be non-palpable. You can do the hook method as well. It shows you how to do that, but I prefer that you do it the way that it's shown in figure 21-25. For the spleen, you do the very same thing on the other side. Normally, again, the spleen is non-palpable. It should not be felt. If you feel it, it says it's at least 3 times its normal size. You can reach your left hand across the abdomen, or you can go to that side. About the 11th to 12th rib, lift up to support it again. Place your hand in again and have them take a deep breath. Again, you should not feel anything. Then it shows you how to feel of the kidneys and palpate them on page 550. You will search for the right kidney by placing the hands together in what we call the duckbill position. Pressing your 2 hands together firmly and ask the person to take a deep breath. In most people, you'll feel no change. Occasionally, you may feel the lower border of the right kidney. Otherwise, it's normal if you don't feel it. The left kidney sits about 1 centimeter higher than the right, and it's non-palpable usually normally as well. So you might feel the right If you don't, it's okay, but you should not feel the left at all. And it shows you how to palpate those on page 550. You're checking for tenderness, you're checking for distension as you're doing that. And then the last thing it tells you to do is the fluid wave test. And it talks about the fluid test on page 543. The fluid wave, first you test for a fluid wave by standing on the person's right side. Place the on or edge of another examiner's hand or the patient's own hand. Place your left hand on the person's right flank area with your right hand reaching across the abdomen on the left flank, and give the left flank a firm strike. So you'll just kind of pop it on the left side. Okay. If ascites is present, the blow will generate a wave, a fluid wave through the abdomen, and you'll actually see it. If the abdomen's distended from gas or adipose tissue, you'll feel no change. So that is a positive fluid wave would occur when someone's got a large amount of fluid in their stomach, such as ascites. Okay, so that is checking for the fluid wave. All right, so that takes care of the abdomen. Then we go to the musculoskeletal system, which is in the next chapter. In the musculoskeletal system, you can see here that we're going to be gathering a lot of data. And y'all did this on someone and then actually documented it. As far as doing the assessment of the joints and the muscles, you're going to be inspecting each joint and muscle for crepitus, wasting. Then you're going to palpate each joint for enlargement, edema, and crepitus. Then you're going to inspect the spine for configuration and tenderness. So you're going to be looking to make sure that it has the right curvature of the spine. Then you're going to, and this is on page 594 about inspecting the spine. You'll have them turn over and bend over as you're looking at for any scoliotic deviation. Talks about that on page 596. Then you're going to actually do range of motion of the spine. So you're going to have them bend forward, bend back, and bend side to side. Then you're going to do complete range of motion of the upper and lower extremities. And most people combine that with the inspection and palpation. As they're doing the range of motion, they will inspect and palpate. You will need to do range of motion of all joints of the upper and the lower extremities. So make sure that you view this chapter before you start the musculoskeletal system. That's worth 10 points. Then you will go lastly, or you can do this throughout, however you want to do it. You can change this up a little bit, however you want to do it, as long as you do everything. The neurological, the 12 cranial nerves, can be included throughout, or they can be done separately. That will be up to you. The neuro chapter, this all starts with cranial nerve assessment on page 633. So that goes over the complete cranial nerve assessment. You're also going to be assessing the mental status and speech, as well as motor system, looking at their gait, balance, and coordination. It goes over how to test for the Romberg test and the gait, looking at their gait on page 637 through 639. So you can read over those. Also, testing for coordination is on page 640, where you have them either do their hands back and forth real quick in a rhythmic manner, or they can touch each one of their fingers, okay? Then they will do the finger-to-finger test, where you move your finger and they touch your finger. All those tests for coordination. Finger to nose, and then heel to shin. So make sure you look over all of this section and that you do all of those in there. The sensory system does light touch, and that starts on page 641. It talks about light touch on the bottom of page 642. You're going to apply a whisk of cotton to the skin. Stretch the cotton to make it long and brush it against the skin in random sites with the person's eyes closed. Ask them to say yes or now when they feel it. You will do that on the upper and the lower extremities. You're checking for decreased sensation. You will do number identification where you have them close their eyes. You will draw the figure in their hand, like the figure 8, and have them identify what they drew, what you drew in their hand. This is on page 644. That's called grathesis, or in this case, they drew the figure 6. Ask the person to tell you what it is. Grathesis is a good measure of sensory loss if the person can't make the hand movements needed to figure out what is going on. The inability to distinguish numbers occurs when there's lesions at the sensory cortex blocking sensory impulses. So that will let you know there's some type of lesion there. Also, you would check for stenogenesis. That's number identification. That is when you do test the person's ability to recognize objects by feeling their form, size, and shape. So you could put a penny in their hand, a key in their hand, whatever, but you ask them to close their eyes and see if they can tell you what it is by feeling it. Problems with this occurs again when people have lesions on the sensory cortex. A lot of people who have stroke lose the ability for stenogenesis and grathesis. Then you will do sharp and dull. Checking for sharp and dull, you can do that on mainly by checking for pain, and this is on page 642. You can see here that they broke a tongue blade in half, and they're using one end for sharp and one end for dull, and you ask the person to close their eyes and tell you when it's sharp and when it's dull. And again, if they can't do that, then they have lost some kind of sensory deficit. Then you have what's called 2-point discrimination. Let me see where the 2-point discrimination is. Not sure where the 2-point discrimination is. But what you do with the 2-point discrimination is that you will take 2 points and you will bring them in closer and closer together, and the person will tell you whether they feel two sensations or one sensation. And again, I can't at this point put my finger on where that's at, so you'll need to look up the 2-point discrimination and make sure that you're testing for it. It also shows you in there how to test for the reflexes, and those are hard, so make sure that you are reading carefully on pages 643. I found the 2-point discrimination too on page 645. 2-point discrimination tests the person's ability to distinguish two simultaneous pinpoints on their skin. So you apply the 2 points of an opened paper clip. So you can take 2 paper clips. Take a paper clip and open it wide, and then just keep it moving it closer together until they perceive that the two separate ones are one. It says in here that the level of perception varies. It's most sensitive in the fingertips. So a lot of people do it in the fingertips or the upper arms. About 2 to 8 centimeters is normal. An increase in the distance, again, indicates sensory cortex lesion. So someone who's had a stroke may not be able to identify that as well. Reflexes, make sure, again, starting that you're testing those really well. Starting on page 646, and you will need a good reflex hammer. Shows you how to do the biceps, how to do the triceps, the brachial radialis, the quadra reflex, or the knee, the Achilles reflex. It shows you several ways you can do that. And then the plantar reflex is on page 651, where you take that, turn it upside down, and do the J to see if they have a plantar reflex or not. Okay, that's what you'll be doing, and then you will be grading those according to page 645, with the 2+ being normal. And then it tells you there you can grade them 3+ and 4+. If they're hyperreflexia, that's an exaggerated response. That you would see if someone's got some kind of higher cortex level dysfunction, usually an upper motor neuron lesion. And then if it's diminished, Usually it's a lower motor neuron problem that they're having if you're getting like a 1 plus or a 0. Now, some of them are hard to get, and you may only get a 1 plus when you're doing the reflexes and practicing them. If you have any questions or concerns about anything on this checkoff, again, please do not hesitate to email me, or I can set up a one-on-one conference with you and go over anything you're having issues with. Thank you.